Good morning, everybody. Welcome to the RCN webinar. We're going to start at 8:02, so one more minute. Okay, hi everybody. Welcome to the first webinar of 23-24. I'm Allie Boehm. I'm one of the co-PIs on the RCN. And we wanted to first off remind everybody that you have to re-add to your calendar the webinar series when you get a reminder from Zoom. And we'll send a note about this as well to remind everybody. So I want to introduce today's speakers. So we have Cresten Mansfeldt, who's an assistant professor at University of Colorado at Boulder, who's going to be talking about his recent project on ethics, which we're excited to hear about. And then Kata Farkas, who is a postdoctoral research officer at Bangor University in Wales, who will be talking about wastewater surveillance beyond COVID-19. So we're really excited. We're going to get to the speakers in a minute. Just a reminder about the rules of the webinar. Remember that you need to put your questions in the Q&A, and then there will be moderators who will ask your questions, and you can upvote questions during the webinar. And then Sarah's just going to say a couple things.
Yeah, so we have a normalization workshop coming up. It is September 7th from 10 a.m. to 12 p.m. Pacific time. And the goal of this workshop is to discuss data adjustments that we carry out on data prior to collecting that sample. And the aim is to think about this in the context of a newly discovered pathogen in which clinical data is either non-existent or scarce. Everyone is welcome to participate, but pre-registration is required. And then I'm just going to go ahead and put that registration link in the chat. If you go to the next slide. And then just some other ongoing activities. So we have our monthly journal club, roughly monthly. It happens, it's led by students mostly, and they pick a journal and we talk, a manuscript and talk about it. And then we're also always accepting webinar nominations for people to speak at this webinar. That link is also in the chat. And then I encourage everyone to join our email list. This is how you hear about all of our activities and what's going on. Feel free to just email me, or you can also go to our list page, which again, another link in the chat. And you can just go to that page and then click ask to join group if you are not in the group, and then you'll get all of the emails about everything that we're doing. Great.
Hey, Cresten, you can go ahead and share your screen and begin. Thank you.
Thank you so much for the invitation to speak today. And I'm glad to have the opportunity to talk about a little bit of the kind of ethics and social aspects of things. This is an area I always start off with a primer. I am not a bioethicist. I am not a social scientist. This was something that was really stemmed from being curious about wastewater practice overall and really analyzing how my own actions and also the field was operating and developing over time. So today I'll be talking about the ethics of the next target. So what did we learn from wastewater testing in support of public health from SARS-CoV-2? And how can that broadcast further into the future? I often think more also on the global context of what's happening. And a recent hydro waste database that was published from a different research group went through and actually cataloged where across the globe all the different wastewater treatment plants are, and also what size of population that they serve. One thing that really strikes me from this atlas is when we consider that about 1.34 billion individuals live within this region, and we compare it to almost an equivalent population of 1.18 billion, we find that there is different access to waste streams and sanitation networks themselves. Additionally, when we map this, when we're talking about the next targets, where are we concerned about potentially emerging or re-emerging threats across the planet? We find that there is actually areas where the CDC has long known about different threats that are very valuable to monitor for. This recent publication from 2020 actually was reinvestigating some of the maps that were previously out there for where is it useful to be monitoring for these re-emerging threats. So one thing is that our cultural organizations surrounding our waste streams themselves provide different opportunities to be able to detect and monitor for specific pathogens. And the nature of solid waste and wastewater globally is inherently diverse. It's reflecting the community infrastructure and how the community approaches waste itself. And this becomes a question as we're moving forward, is how do we balance cultural versus technical classification systems? And this is also very visible when we actually map the location of the wastewater treatment plants to the different viruses of emerging concern. So this is a bit different talk for me. It's always kind of looking at what are we surveying in the first place. And with waste, I always go back to a seminal 1960s book that came out by Mary Douglas entitled Purity and Danger, where it was really looking at how human anthropogenically and culturally really organizes around waste. And it really delves into some key points. And of the 5 main key points, I'll be talking about 4 today. So waste as a cultural classification system, pollution as disorder, rituals as social cohesion, and this concept of body as a symbol. So first, for cultural classification systems, within the United States, we have legal definitions around waste. One thing is when I teach the solid waste course here at CU Boulder, we struggle with actually finding a coherent term, because often it's a very nebulous concept of being discarded or thrown away. Similarly with wastewater, it has within its definition through the EPA terminology that makes it even more flexible and interpretable, where it's a potential source of contamination that is being discharged from a facility. So in legal usage, waste is a pretty vague and subjective term. And this is also something when we think about that actual versus potential contamination. I had an undergraduate student researcher in my laboratory, Jessica right there, who was really investigating how fecal matter moves through our sewer networks itself. And one thing is you could think about the contamination load switches through time. So she created a fluorescent fecal matter, flushed it down our laboratory toilets, and then we were able to monitor as the pulse would go through the sewer network itself. And so on the chart there, you're actually seeing us monitoring the background fluorescence and then the pulse of the flush of the toilet coming through. So this sewer microbiome and the sewer experience changes over time because each flush interacts with a different time period. And so that contamination flow is unique. At the social central core of wastewater surveillance and wastewater-based testing and all these terminologies that we have surrounding it is an agreement surrounding the definition of waste itself. And so this definition is really cultural and will shift with time and also location. And it's also linked to perception, and it's not consistent with the idea of necessarily contamination. So we have optimized systems first to this biological central core that the body must expel components. It must expel viral particles and discharge it within the waste network. And we also have to require investment into the maintenance of this social agreement and how people actually participate within our wastewater infrastructure. For example, like pollution as the disorder. So wastewater surveillance is based on this, that the virus is a public health indicator and should not be present and it's in a disordered state when present. I use all this weird terminology because it's one where we have a lot of concepts around what is ordered in waste and what is disordered. For example, if we look at and ask artificial intelligence now to provide us a photorealistic toilet in a bathroom, it actually is able to do this pretty well. If we even ask now artificial intelligence to say, well, we have a toilet on the moon, it actually is not too bad at generating an image in this framework, although it has a moonrise over a moon itself. Next, I tried to ask it for a photorealistic toilet in a kitchen next to a stove and refrigerator. The first warning sign that I got was I actually got flagged to have to appeal to generate this image. There was a huge barrier where there was a taboo associated with asking for this. And then additionally, when the actual artificial intelligence generated it, it failed pretty miserably at trying to achieve the idea of combining an idea of a kitchen with an idea of a toilet. And so we have pretty hard barriers in how we have structured some of our concepts. So our ordered state biases surrounding waste is even showing up in AI. This also leads to some of the rituals that we have built into our interactions with sewer networks. For example, there is always the ritual surrounding the flush. But if we just change a technological component to it, you can imagine that your experience and your ritual within whatever bathroom this is alters just slightly, where it goes from a manual interaction to an automatic interaction. And I had one experience where I found there was a pull chain that was in front of a toilet in an international bathroom that I did not know. So being an engineer, I pulled it. Nothing happened, which was even more concerning for me. It turns out this is linked to a warning light outside just to have if you have any stress or concerns. But this is where if you are interrupted on your ritual, you may be surprised and end up in a discomfort state. And all of these rituals merge within our sewer network. We create this social body of material that's moving through that in itself has developed over time and space. I had another undergraduate student, Connor Gilpatrick, that was working to really explore the Denver sewer network and seeing what materials were present, when were the entire sewer mains installed. And over time, there's a significant fingerprint and bias that's associated with what services what specific networks overall. And you can see this from the total pipe length that was installed since the 1880s on within the Denver metropolitan area, and the install and also refurbishment dates of some of the pipes. And all of this then goes to that larger social body. So where a lot of the contributions and a huge amount of collaborative effort has gone into is establishing, running, maintaining, and reporting this surveillance network that's across the United States. It all feeds into the National Wastewater Surveillance System that is actually used as a fingerprint for social sickness. It's looking at how a disease is moving through the entire national and social body. One thing to look at this, though, is another book that I turn to is often The Sapiens, and the graphic novel version of Sapiens is a really good read as well. And one thing that happens is this balance between mythology versus reality. So we're very good at also developing a lot of these ideas that are technically fictions, where we have the concept of nation state. We also have the concept of public health in of itself. These different kind of concepts are organized to be able to deliver reality in different ways. One thing that happens in this, though, is we must be careful that what we're developing in the fiction standpoints, this mythology that is very useful, does not come in conflict and potentially harm the people that are involved with it. And this gets to my broader reflection of what my interaction with the sewer network was. We have a very large collaborative social body that also for $25 on Amazon and a little bit of muscle energy, most people can access. So it becomes this balance as how do we actually respect the social body and move through it in an ethical framework. It's a very semi-public system. When I was up and operating for a monitoring campaign here at CU Boulder, we would share the data and to other entities to make sure that the public health information was valuable across the communities. But we also refrained from a dashboard, mostly because we were concerned with potential tampering. So you see one of our stations right here. Usually it's not tipped over like this. Somebody obviously was a little bit curious. Surprisingly, we only had about 2 interactions with our stations over the entire course of a year monitoring campaign across 23 different sites. So one thing is kind of this idea of how do we protect the sample integrity so that you could also prevent poisoning or planting evidence event, while it's still maintaining this very collaborative public social body. And furthermore, when we think about that next step, we have now a very good tool technique, this fiction that is developed. How can it be in service of public health? Other types of targets that we'd see, you could potentially monitor hepatitis. But one of the issues with hepatitis is there's already stigma associated with it in certain contexts. So then when we're thinking about moving forward with this and expanding even further into other techniques, we have to be careful with this idea of what stigmas potentially we're bringing into the social body. And when we go into the mass spectrometry realm, this opens up the ability to see the wide diversity of chemical components that are moving through our waste infrastructure. And when we actually explore some of these specific components, we can zoom in and say, well, what pharmaceuticals are there? And each specific pharmaceutical has a different history and stigma associated with it as well. For example, in this case, we're looking at a pre-exposure prophylactic, so what is commonly termed in more usage is PrEP. And so PrEP itself is a very ionizable compound, something that mass spectrometry would pick up very well. But there's actually a substantial stigma associated with some of the trade name pharmaceuticals that are moving through. And when you associate this with that direct harm concept, there's been cases where individuals have lost access to having health insurance because of being identified for being on this prescription pharmaceutical. So all of this kind of combined together is what targets you're selecting may have different types of stigma and also potential harm associated with them. This was recognized by many teams early on, and it's one where the care and consideration surrounding the development of wastewater-based surveillance has been integrated with this idea of social responsibility as well as ethical practice since really the advent of the SARS-CoV-2 application. And from the Kaufman et al. Paper, early in the pandemic was really identifying that we should proactively engage scholars from multiple disciplines to really methodologically look at the broader implications of the work. And this really inspired me to early on form an approach to actually use some of the different methodological frameworks that are out there and summarize it for how we have been performing, and then moving forward to say, what are some of the best practices? So in the 2021 time period, I was fortunate to attend the WEF Public Health Surveillance Conference that was held in Cincinnati. And there I was presenting on a framework analysis of interpreting all of these previous types of surveillance framework ethics and applying it in a very crude method of saying it's not a critique, but opening for areas that we should invest in for review or further analysis. So it would be an area where I created a category and then had it say review likely not required. It seems that it's well satisfied, or further investment of either the field or individual practitioners should look into what best practices are in that realm. Using this approach, I initially sat down as kind of a one-man approach to it, but then I was able to broadcast out at the WEF conference and assembled a workshop that was actually looking in a very considered manner of how do we identify the key categories, as well as how do we identify how to rate what either review should go on. So this was the SUSER working group. And out of the SUSER working group, we had two publications that emerged. One was more of a viewpoint piece that was talking about the balance between what are some assumptions and where they might come in conflict. And then the second was actually the framework itself. Delving into the framework here, we were able to really coalesce around 11 key categories to really investigate into analyzing how the operation of and communication of the campaign was going. These really are legitimacy, unfair disadvantage, data stewardship and protection, creation of some of the unwanted precedents, and then further with awareness, right of inspection, and a lot of community values. Rather than going through each one of the key points and questions there, it's really to see how these are not necessarily saying best practice, they're just more of the questions that should be asked and actually see if the campaign has considered and brought them into co-development with the monitored communities, as well as those who are running the campaigns. And we broke it out into very specific ideas of, well, maybe if you identify this category, you might want to review it further to see how you engaged it, to see how you're partnering, to make sure that you have the buy-in, but also the maintenance surrounding the campaign. When we applied this to approximately 60 previous studies that were published in the early phase of SARS-CoV-2, we were then seeing, well, where on the framework would our committee see that these different studies were? We found that some of the areas that were highlighted for not necessarily needing further review, so these were areas that had well communication and well standing, was basically saying, is the technique broadly applied? And also this idea of the consequence of inaction. If you're not applying it, was there a negative outcome potentially for the community? Another area that we started to find that wasn't necessarily as communicated was data stewardship and protection. How were we actually incorporating the idea of privacy, data protection, and maintenance? And broadly across many categories, we see gray is one of the biggest bars right there. It just was not available. We weren't necessarily communicating in this realm because we were very focused on that development of the methodology, so the development of the fiction. And through that, that makes it so that we were maybe talking more technical rather than on the social side. And by building this consistent framework and allowing us to engage with saying, it's like, well, how do these different techniques go? When we have a new technique come online, such as using eDNA to identify missing persons and persons of interest, it then allows us to communicate in a rational manner how this adaptable tool can best serve and be best deployed. And this main aspect of the framework centers on that idea of the community benefit, and also the idea of not having that individual harm to serve a larger narrative. And so this engaging through this lens can prioritize this use-inspired research and allow the ethical framework itself to evolve as we find different areas that were not necessarily considered, or as the idea of waste shifts over time, the framework itself will have to shift as well. In more closing, one of the statements that we were able to communicate outwards in the Viewpoint article is that this collection, this social body, is that you're initially it's really structured along that flow path to the sampling point. And so it is exclusionary to many populations. And even beyond some of these structural biases, their access has been denied to toilets based on many factors. And so while this wastewater-based surveillance can provide information, we have to acknowledge where some of these biases are and limitations, so that as we're developing and thinking in that global context, that we can use wastewater-based surveillance to also advance the sustainable development goals around sanitation. And with that, I do thank you for your time today. I have a large acknowledgments for this path that I've been on, everything from the sampling team who was really deployed in 2020 and 2021 across the University of Colorado campus, to the smaller team who has really thought up some of these ideas and bounce ideas and how do we integrate the practice of wastewater management with also social and equitable access to both public health and to sanitation resources. And with that, I would thank you for your time and happy to entertain and answer any questions.
Thank you so much, Cresten, for that really thought-provoking talk and taking the lead on thinking through all of this really carefully. If anyone has questions, please put them in the Q&A. We have maybe 5 minutes for questions, so I'll start off with a question. So it seems like, you know, based on your presentation, that there are things to consider where people actually like cannot and don't contribute to the sewer network, so they are like left out of the surveillance efforts, which is bad, could be construed as bad or negative. And then there's people who are in the sewer network, and that also could be bad if we're like sort of misusing the data or using data from wastewater. Like, how do you how do you think about balancing those two? I mean, that's a really big question, and I'm sure it's discussed in your paper, but maybe you can just say something about that for a minute.
And I think this is that push and pull where it becomes weighing of community values, where on the one hand, it could be community access, where people want benefit from the surveillance, because one thing that's been demonstrated is the strong power of using this to inform resource allocation at the university scale to intervene with potential outbreaks. So that's where you can bring the surveillance to benefit to the community, but simultaneously there's been communicated concerns around privacy, potentially moving too far upstream. And so this is where you have two different components to, especially in the public health, to weigh as you're moving forward. And I think it's one where there is no direct and definitive answer. And I know there's a lot of creative solutions that different public health agencies have been deploying, as like monitoring at community centers, potentially a good balance between it, or alternatively looking for ways to monitor for when septic systems get dropped off, when the trucks come back to pump out what they collected at septic systems, for expanding access to those who might be not on the main sanitation network, as well as having ways to ensure that privacy and data is handled. So I think it's one where it's a continuous conversation, and it can change within your community as your community itself changes.
Thank you for that. I have another question for you from the audience. So have you considered putting together like a checklist or something for researchers for this, similar to like the EMI or the MIKE guidelines for molecular measurements?
So we do have the full framework, and it's this giant 3-phase, and there's about 33 categories that are associated with it. It just always becomes, as we were going through it, that's where almost the inspiration started from it. But the more we tried to box it into a checklist, the more it became less of saying, oh, I'm doing this correctly, to be much more of, I'm aware of this, and this is something that we're proactively monitoring and engaged in. And so a good component associated with the discussion was our comparison between using surveillance as a research tool and following much more of what an institutional review board would be looking at, versus using this type of framework much more as a continuous reevaluation and engagement of kind of the best management practices of the campaign.
Okay, great. We just had a question come in the Q&A. So the question is, do you think we as researchers should be responsible for regulating our own actions to ensure we stay within ethical bounds, or should we be asking for external oversight that governs how wastewater data should be used? Did you get that?
I would say, yeah. So I would say both. It becomes one where it is up to everyone who's participating in it to continuously be engaged, and this is actually in some IRB training where they discuss that it's also this continuous process of reevaluation and just seeing what the best health of whatever practices that are going.
Okay, great. And I think we're out of time, but I'm going to ask one more quick question here because we did start a couple minutes late, which is, do you know of example, like, can you provide an example where the public actually protested the use of wastewater? I mean, this is all this is to sort of make sure that doesn't happen, and that people, I mean, it doesn't mean that the public actually has to protest for there to be a problem or for it to be in that form. But I'm just wondering if there's an example where you know that there was a group who really didn't want their wastewater monitored, who like got up in arms over it.
I haven't heard too much of like a controversy to shut a system down. I think there's been barriers for launching some new systems in different communities. And so I think that's where potentially demonstrating clear communication and guidance would also make it where some communities that have been previously hesitant would be welcoming to a valuable public health tool.
Okay, well, we're out of time, so Kata, you can begin sharing your screen, but Cresten, 2 questions came in from Rose Cantor from UC Berkeley, and also Tarja from Finland put in a question, 2 really interesting questions, so maybe you can type those answers during this talk. Okay, thanks. Kata, take it away.
Thank you as well for being here. It's really great to see you all. Can you hear me all right and see the screen and everything? Yeah, okay, thank you very much. So yeah, I'm Kata Farkas. I'm at Bangor University. I have been here for 8 years now, and I'm mainly interested in waterborne viruses, how they pollute the environment by wastewater, and what the applications are for drinking water use, bathing water, and so on. So it makes sense that in 2020, we started wastewater monitoring here in the UK, our lab being the first one in the country doing so. And we've been doing it ever since. So as for the WAF program, so all 4 nations have had their own programs. Some have stopped, some have been paused already. Ours is paused now, but we will restart very soon. We started in September 2020 with the Welsh government, with only 8 sites at the time, sampled 4 times a week, but it's been expanding ever since. And at the end, we have had 47 treatment sites where we take samples 5 times a week. And we also have up to 10 hospitals that we sample 4 times a week. We have several targets now, not only SARS-CoV-2, but influenza, RSV, and some enteric pathogens, along with AMR and some other bacterial pathogens that are emerging and of interest of public health. As for what we do, just some technical details on how the samples are processed, so you have some idea where the data I show you comes from. We do basic chemical analysis, including ammonium and orthophosphate, pH, and so on, for quality control and also for population estimates. For practical reasons, we decided to use the polyethylene glycol precipitation for virus concentration in wastewater. It has its pros and cons. We have several papers where we compared its performance to other methodologies. And so far, we've been very happy with it. It works pretty well for our targets. Then we use RNA DNA co-extraction for viral targets, followed with qPCR and RT-qPCR and or sequencing. We also have a great sample archive. Basically, all samples taken since September 2020 has been archived as raw material and as the RNA element as well. So in case something emerges, we can always go back and check whether we have seen it in wastewater at an earlier time. For SARS-CoV-2, we have done much research and surveillance as well. I'm not going into the details of that. I'm sure there has been many talks around this already. We do see the trends in concentration, which aligns pretty much with the case numbers, and we are quite proud of the sequencing effort that we have done, especially now as the clinical surveillance has gone down. It has been a great data set for the government and public health authorities to make decisions on COVID-19, lockdown measures, restrictions, and so on. Now let's go beyond COVID a bit and see how we can use this approach for other pathogens, namely influenza and RSV, because this is what we have been doing for a year now. Actually, we started last September. So we can detect the virus with qPCR as a gold standard, I guess. However, for influenza, we found that it always needs updating and checking for mutations and so on, because influenza specifically, it mutates very fast, it recombines as well. So we just have to make sure that the primers and probes that we use actually catch those strains that are currently in circulation. But then you have to make sure that the assays is modified, they are still reproducible, and you can use the new assays for temporal trends and so on. The other concern that was brought up by public health is flu vaccination and whether we would oral vaccine in the samples, which then wouldn't indicate case numbers, but rather the vaccination. So this is something to look into as well. And also, how about the animal strains like avian flu? There's a great pandemic now, I believe, that affects not only birds, but many mammals, humans as well. So how can we make sure that what we detect is actually a virus that is of human health concern and not a strain that circulates within other mammals and birds only? Now, sequencing can be a good solution for that, but as you know, especially for influenza, it has a segmented genome. It's pretty hard to sequence, especially in an environmental sample like wastewater. It's much easier with individual cases where it is unlikely that so many different strains would be in the sample. But in wastewater, that's the point of it, that you have a mixture. So it can get very complicated. We have found that some panels that are available commercially can be pretty good, like the RVOP panel from Illumina. However, it does provide sometimes false positives for some strains. You have to be really careful with the quality control steps to make sure that the results are actually accurate. Another concern when it comes to WBE and respiratory viruses like flu or RSV is the virus decay in wastewater itself. So what we usually do in WBE is that we collect samples. It's usually a 24-hour composite to get a good coverage of the day. And then we transport it to the lab. It can take a few hours, it can take a day, it can take 3 days. And you have the sample process itself. It also can be time consuming. There's a lot of time from the first sample taken to RNA extraction. And during that time, it is possible that your virus would actually decay. And actually, this is what we found. Our PhD student, Monica and provided this nice graph. What she did is got samples from 20 sites around wells and spiked them with vaccine strains of influenza virus and just check the concentration of the virus after 24 and after 48 hours. And actually after 48 hours, there was a great decay. 24 hours was okay, but 2 days, in many cases, it can be too much work. And we did not see this trend with COVID or with noroviruses, other pathogens, but with flu, probably because of its segmented genome and the overall structure of the virus, it does decay. So again, this is something to consider when you want to include in your WBE monitoring. Now, I would like to just share some of the results that we have so far from September to May, is what's shown here, I believe, on influenza and RSV numbers. This is just the detection rates across the well sites, so that's 55 sites altogether. What you can see is a great peak starting November, ending in January, which actually coincides with the seasonal influenza outbreaks around the country. And we did see some spikes in flu B and RSV as well, but those viruses were significantly less abundant in the samples overall than influenza A. Again, this reflects quite well the national trends that were seen in the clinical cases. Flu A is usually the most prevalent strain, flu B not so much. Some more graphs on how we see influenza in our samples. So on the right-hand side, we see the data normalized by population for each cohort. So there's 6 health boards here in Wales, and we just collated the data for each from wastewater treatment plants. On the left-hand side, you see the national average, and below that, the two numbers, not normalized, just the concentration in wastewater collected at hospitals. And again, you can see the same peaks at the same time, pretty much in coincidence with the clinical numbers. What we also did, well, not me per se, but it was actually Mark Drakesmith at Public Health Wales, who is an epidemiologist, and unlike us academics, he does have access to the actual case numbers in the hospitals around the health boards in Wales. And what he did is try and model and just correlate the hospital admission numbers with the wastewater concentration, flu concentrations in wastewater. And again, what he found is that the peaks coincide, as we saw before, pretty well. And also in some cases, the wastewater signal came before the case number started to increase. However, in other cases, the trend was the opposite of it. Again, I believe possible explanation can be the degradation of the virus itself within the sample, which pretty much affected by largely the wastewater composition. So for instance, if you have a wastewater treatment plant that has more industrial input, which can contain dyes or other matter that would promote virus decay, then you wouldn't see the virus as prevalent as in more domestic wastewater samples, which would then mean that it wouldn't provide the early warning that you are looking for in WE. Now, for influenza B virus, as I said, it was way less prevalent than flu A. However, we did see that when there was an increase in case numbers, there was an increase in detection rates in wastewater as well nationally. But because the virus is so sporadic, we couldn't really pinpoint it to health boards or hospitals or anything like that. But the national plans actually coincided. Same for RSV. It was sporadic again, even though there was a great outbreak in Wales from November to February last year, beginning of this year. However, the concentrations were really low and the detection rates were really low. So it was a bit hard to see the actual trends. Mark then at Public Health tried to say modeling with hospital admission numbers and wastewater signal, but because of the noise levels, it wasn't that as good as for flu. However, for RSV, we see more instances than a wastewater signal came before case numbers. So there is a better chance to use RSV in wastewater as an early warning as it is for flu A. Again, it can be that RSV, because of its structure, doesn't decay as fast as in wastewater. Now about the sequencing, which was really, really important to us because Public Health has been pushing the prevalence of animal strains within wastewater. So we really have to look into it. And again, as I said, we use the RVOP panel from Illumina to pinpoint that out. It's quite easy to set up. It doesn't take very long to do that. I think 3 days, and you get the data. So it is feasible for wastewater-based epidemiology. However, you do need to consider the price. It is so expensive, like I couldn't believe when I saw the first quote. But if you need a good coverage, it is an option to use this panel. And we did see RSV in the samples. taken from wastewater treatment plants, but not in the hospitals. However, we did see RSV signal with qPCR in hospitals as well. As for influenza A, that was prevalent in both municipal wastewater and hospital wastewater as expected. And we did see even, as I mentioned, the H5N1 in some wastewater treatment plants, but after a more rigorous QC than what was provided in the original platform, those were considered false positives. So again, just have to be very careful on your QC with the sequencing, especially when it comes to wastewater, where you should have lower read numbers than you would get with clinical samples. And again, we did see influenza B as well in both municipal and hospital wastewater with sequencing as well as with PCR. So again, this just helps to understand the signal a bit better and verify the qPCR findings. So in conclusion, it is possible to monitor respiratory viruses, not only SARS-CoV-2 in municipal wastewater and in hospital wastewater, and there are some implications for other your source sampling like hotels or prisons or aircrafts and airports and so on. That has been shown in our other research and in international research as well. However, the sampling and sample process really has to be timely, otherwise we do lose your signal, and then early warning is not possible. Even then, I mean, we still have a good data if you want to do sequencing and look into which strains are circulating, or just to have a snapshot of trends and viruses circulating in the community. But if you really want to see temporal trends, and you want to use it for early warning, this is something to consider. Also, the assay development, as I mentioned, and you really need to constantly update and look for any new variants, any new strains when it comes to viruses that mutate so fast, like flu. And also for virus sequencing, as I said, it is possible with this panel, but it is expensive and it has to be optimized, no matter what the suppliers say. You really have to be careful on how to use that data, how to present the data, and how you do the actual QC on your data. Some further work as an outlook, just in case you thought it was over. No, it's not. I still have like 35 slides to go through. No, only a few. On further work, what we also do and look into as pilots now is the inclusion of other relevant viruses and other pathogens. Here you see some trends of norovirus G1 and G2. And we are quite proud of these because it looks like that for noroviruses, wastewater surveillance can be used as an early warning system. In our wastewater treatment plants, we did see an earlier rise in wastewater signal than what we saw in case numbers. And I don't know about the US, but here, norovirus surveillance in hospitals and GPs, it's very sporadic and very unreliable. But if we apply wastewater-based epidemiology, then we would see that there are cases on rise within the community, and then it can be implemented in hospital routines, and then that can affect the routine work at hospitals and maybe prevent the closure of wards and so on, which would delay care for the sick people. As for AMR, again, we've been doing AMR since January last year. We see all sorts of genes circulating with all sorts of pathogens. Anything you can imagine, it is in the wastewater. This image is from Dr. Will Pyrie from Cardiff University, who has been leading on the AMR side of things. So we have an extremely large and diverse data set. What we need to pinpoint is which pathogens and which genes do we really need to look into for temporal trends. But again, it is possible. It can be done with sequencing quite an affordable way. So it is something worth looking into. Another thing that we are looking into now is the viromics approach, so non-targeted sequencing for wastewater. In a previous project, we did find that it is feasible for wastewater samples. We did find all sorts of emerging and new human pathogens in wastewater using that approach, and new strains of existing pathogens as well. However, the problem with that is it takes forever to analyze the data and to do the lab work and go through the pipelines and everything. So what we are looking into now is how to reduce the actual time to provide data for public health purposes as soon as possible. And there's also the other aspect of the work, which is chemical analysis. We worked with Bath University on that one. And again, we had quite a few data on drugs, antibiotics, hormones, and so on, just to diverse our portfolio and have an even better understanding on the health and well-being of people within wells. And that leads into the One Health approach, which we also have been working on here at Bangor University, to understand the effect of wastewater contamination on animals and the environment, not only on human health. So this is something that we have now about 3 or 4 projects ongoing to produce data on that. So thank you very much for listening, and I also like to thank the amazing team at Bangor University, at Cardiff University, and other partners working on that project. And again, for you for having me here this morning. So thank you.
Great, thank you, Kata. Great talk. So just a reminder for everyone, if you have any questions, put them in the Q&A and we'll try to get through as many as we can. So the first question in the Q&A, and there's some that came from the panelists in the chat as well that I'll move back and forth from. In your RVOP analysis, how did you determine that a hit was a false positive?
I like these questions. I didn't because it was done by my colleague, Rachel Williams. But if you put me in contact with the person who asked the question, we can get back to you with the technical details next week.
Great. So I'm going to combine a few questions. Maybe they shouldn't be combined, but it seems like this mutation of influenza A is quite an issue. Is there another genomic region that you could target that may be less susceptible to mutation or help you to get around this issue? And then there was a semi-related question: is there a preferred repository for these genomic sequences, these influenza A genomic sequences?
So for the qPCR side of things, what we do now is to test different assays. Some of them were just published online and seem to be reliable. We are also in contact with public health well and trial their assays as well. And we also rely on the WHO assays. So we use one routinely, but sporadically we do use the other ones just to make sure that we pick up everything. Also now we set up quite a good data streaming from public health and UK HSA, so that's the UK-wide Health Security Agency, who provide us with more up-to-date details on the strain that are circulating within the communities. So we can just double check as we go that the primers and probes are still picking up the latest strains. So far, this is what we could do. We are always open for more suggestions on how to make sure that we pick up the right strains. And what was the other part of the question? Sorry.
The repository for the influenza A genomic sequences.
We don't have that yet because the data technically belongs to the Welsh government, so we are unable to deposit the sequences just yet.
Okay. Did you have to change your sampling frequency or sampling design for these new targets based on your observation of the faster decay or any of these other factors?
So far, no. We have a pretty good rhythm, which enables us a 24-hour turnaround. We tried other methods for sample concentration, which are less time consuming, but those didn't provide better data or better quality than the polyethylene glycol one. So we are still sticking to that one. Again, this is something that we look into from time to time as a quality control to make sure that we get the most out of the samples.
And sticking on this topic of decay, what was the best preservation method, sample preservation method you found? Was it low temperatures or some other preservation of the signal?
For the raw samples, we just process them as soon as possible. Upon arrival, within a few hours, they are already in the PEC solution. So that's one way to tackle it. We didn't use any preservation on raw wastewater samples. We did try on the RNA extract to use additional ethanol and so on, but to be honest, it didn't help. It was just another step to introduce. So we didn't bother with that. Everything is stored at -80 as soon as possible. So we process the samples upon arrival, and next day they are qPCR. Following day, the samples are in the -80, which is a good way, I think, to preserve viruses, even without the addition of preservatives.
Great. And I think we have time for one last question. You mentioned near source monitoring at airports. Do you think it would be possible to use that data to infer international transmission of different variants or how else the virus might be moving around populations?
Well, yeah, this is something to look into, isn't it? So there's this global surveillance now being set up by the Gates Foundation. London Heathrow Airport is part of it. So I think this is something that we will see. We did do a preliminary study on wastewater from airports and aircraft. And it showed that, yeah, it is possible to do the qPCRs and to get signals. The sequencing, on the other hand, that was a bottleneck. It's still something to be sorted because the samples are just so full with everything. The groups working on the sequencing aspect found it really hard to get a good signal. So I think if that is sorted, the genomic side of it, it would be a really good way to understand global movements of viruses or other pathogens.
Awesome. Well, thank you so much, Kata, for such a great talk. And I'm sure both Kata and Cresten would be glad to answer any additional questions that come up over email from anybody that's interested. And thank you also, Cresten, for a great talk and everyone for coming. So hopefully we'll see everybody in a month for October's webinar. And a reminder to sign up for our email if you haven't. And we have a workshop next week on sample normalization and an upcoming student journal club as well. So thank you, everyone, and hopefully we'll see you virtually soon.
Thank you very much for having us. Have a great day. Bye.